All right. So today, again, everyone, not everybody's here quite yet, but we have Dr. Lee Radish. I hope I'm saying that name correctly. It's close.
Yep,
He's going to be
close enough.
talking about buprenorphine for chronic pain. It was a talk that he gave at the ASAM meeting out in DC, and it was a fabulous talk. So we'll bring him on today.
So we are going to be switching over to a new iEcho platform. So Katie will be sharing the link to do so towards the end of the presentation. So click that link if you haven't already and get registered so you are ready for our changeover on December 6th.
Yeah, be there or be square. All right, so we have a lot of great talks coming up. We have people from the state coming on next week who did the high-intensity drug trafficking stuff. So a lot of great information on that one. We have Dr. Absey coming from the University of Minnesota to talk about COT, which is another interesting one. I believe I will be talking about poppy seeds on the 25th of October, one of my favorite talks on the poppy seed dilemma. So that one's going to be between those two. I don't know, there's a whole bunch of talks coming, so.
And just make sure that you're registering because there is free CME for these sessions.
Yeah, and make sure, since Lee would probably love to see your faces, that you toss on your video so he can talk to people instead of black boxes. I think we're used to COVID and there's candy pops up, but please feel free to turn them on. Makes it much more fun. So remember, if you need help, both Aaron and I can be contacted. You know, again, I don't want to deal with people's family problems, but patient issues, happy to do that.
And then just a reminder, Stratus Health is the home to the CORE website for additional resources on addiction and MOUD.
Just about everything you could need to know is on there. So this is our talk for today. We'll let, I'm expecting that Dr. Radish is interested in, you have to tell us how you really say your name, that you're, you could maybe tell us a little bit more about yourself and,
Sure.
And then kind of get going.
Okay. Well, first, thanks for having me. I love speaking about anything related to addiction or pain and trying to get the word out. And so thanks so much for having me over your lunch hour. So I'm Lee Radish. I'm addiction medicine. My background's in family medicine. Was actually faculty of a family medicine here in Reading, Pennsylvania. It's about an hour and a half northwest of Philadelphia. So I was faculty there for about 18 years and program director for 6 of those, and loved family medicine, delivering babies, the whole bit. I particularly liked the addiction medicine part of it. I loved helping people through their journey. It was very rewarding, particularly because this is often a population that is underserved, that gets looked down upon by the rest of the medical system. So it's very rewarding. Where I live in Berks County, Pennsylvania, happens to be Caron Treatment Centers, which is a very well-known national drug and alcohol facility. So I actually did a fellowship in that. And so I've been doing full-time addiction medicine for about 4 or 5 years now. And our practice is outpatient, where it's a lot of buprenorphine. We use a lot of injectable buprenorphine, certainly alcohol, other addictions. I do some like sex and pornography, off-label use, things like that. But the bulk of it's opiate use disorder. And then we also do a lot of inpatient consults at the Reading Hospital. One thing that we've noticed is more and more people were getting referrals who have been on chronic opioids. And there's a question of, should they be on buprenorphine? And it's often a gray zone. Well, do they have an opiate use disorder? Or is it, I'm going to put just physiologic dependence? And I hope by the end of this, you're going to kind of be able to say, it may not matter, it may be helpful anyway. So that's sort of the background to this. And I'll see if I could, let me see if I share my screen here. Just give me, here it is.
You know, Lee, I have a friend from Reading, and he was shocked that when you're in Minnesota, you don't use your bumpers to bump into cars while you're parking. I'm wondering if that's a real thing.
You get used to it. I was much better at it when I lived in Philadelphia, to be quite honest.
Okay.
So, let's get started. So again, buprenorphine for pain. And again, I want to make this very practical. And so we're going to go through some things here. I hope by the end, you can list available evidence regarding this, identify patients with pain where it would be a good option, and how do you go about doing this? I should have asked, can you guys see the slides okay?
You're in presenter mode.
You're not.
You're not in presenter mode. I'm sorry.
Okay, let me figure that out.
If you click in the middle of your screen, there's a little like screen looking thing with a line across it. I think you click on that one. Or you can go to the top and go to display settings.
Oh, okay, let me try this.
There we go. Perfect.
Okay, perfect. Okay, so I hope you can safely initiate this. I saw this quote on a listserv actually right before I gave the lecture at the National ASAM talk. I believe that practicing addiction medicine includes proactive care of patients with pain management issues. I push buprenorphine for the treatment of chronic pain. And I couldn't have like planted that quote any better. Couple disclaimers, there's no financial disclaimers that I have. I will be discussing some off-label uses of certain formulations. The other thing is I'm going to be talking about some anecdotal experience, maybe even some thoughts and recommendations. And the evidence, as you'll see, is somewhat limited. It's hard to tease out what's opiate use disorder, what is dependence, acute versus chronic pain. There's a lot of things that are, again, gray zones. So I just want to kind of put that as a little bit of a disclaimer. What I'm going to do is spend just a moment talking about the pharmacology of buprenorphine. I'm sure most of you are well familiar with that. The efficacy when it comes to pain management, some of the research behind that. Talk a little bit about the challenge of opiate use disorder and dependence, dosing, and at the end, I put in for later, I sent the slides, what I'll call extra resources. If people are interested in learning about the safety and the ceiling effect of buprenorphine, some things that are a little more in-depth. And I also put some sample cases in that you can go to later, which may help illustrate the point. I don't think we'll get to those today, but I wanted you to have them to go through. And at the end, I gave a ton of references in case you're interested in following up of anything. So I think since we're talking about pain, one of the first things we need to remember is that pain means a lot to a lot of people. And there's a lot of factors involved in pain: transduction, transmission, perception, behavior, all of these things. And I love this quote: pain is inevitable, suffering is optional. And we've all seen people that have some physical ailment where they should be writhing in pain, but they look okay. And then you have people like me who, if I like stub my toe, I'm virtually in tears, right? So it's variable, and we have to remember that the physical pain doesn't always correlate with the suffering. And what we're really treating when people come to us is suffering. And when you're treating pain, you need to think about what the goals are. It's really about function, right? We don't have a hemoglobin A1C for pain. Even those subjective smiley face scales, let's face it, how good are they? If someone can improve their function, their quality of life, we've been helping them. And that's really what our goals should be. There are some great guidelines for pain. I just want to put some here regarding lower back pain. There's some from the Veterans Administration, the Department of Defense, that, again, your tax dollars at work. One from the American College of Physicians lately, or both really good guidelines if you're interested in sort of some bread and butter pathways, protocols about treating some chronic pain. And I'm sure people are familiar with the Choosing Wisely campaign, which calls for all of us providers in different organizations to try to improve quality of care. And one thing we're supposed to do, not surprisingly, is we're not supposed to prescribe opioid analgesics as long-term therapy for chronic non-cancer pain unless we've really considered the risks. And we all know that there are many people on chronic opioids who have never been reviewed with the risks and maybe shouldn't be. There are also people who should be and may benefit from them. So how can we do this safely? And that's where guidelines come in, such as the CDC, the Center for Disease Control Guidelines. And I just put a plug in for this, that if you are managing anyone with chronic pain on chronic opioids, you should be very facile with these guidelines. This is the standard of care. And I would encourage you to be familiar with them to make sure you're following the standard of care. I've done separate talks on CDC guidelines, but I just want to remind people why buprenorphine comes into play, because it tends to be safer than traditional opioids. Why is that? What about buprenorphine makes it so unique? Well, here's a nice a history of buprenorphine, and you can see way back when it was discovered. But then you'll see in the 80s and 2002 is when Suboxone as we know it came to be. But what I want to call your attention is about 10 years ago, 5 years ago, newer buprenorphine formulations came in specifically for pain. Right? So that's fairly recent. And I'm going to go over all of this in more detail. As soon as my slide advances. Oh, there we go. Okay, so first, another disclaimer. Some people may be familiar that there used to be a big requirement that you need to do this big course to get a special DEA waiver, to get your DEA number changed to an X number to prescribe buprenorphine. Many are probably familiar that less than a year ago, rules changed, and now pretty much anyone with a DEA can do Suboxone buprenorphine. So that's very helpful. So there's sort of no excuses for incorporating into your practice. Very quick review. I'm sure most people on the call know this. Remember that agonists like oxycodone, hydrocodone, Vicodin, Percocet, heroin, methadone bind to the mu receptor, fully turn it on. So it's highly reinforcing. And with those is when you're most likely to develop tolerance. You have the antagonists, like the short-acting naloxone used in overdoses, or naltrexone, the longer-acting version used in opioid or alcohol use disorder, binds to the receptor, doesn't do anything except blocks it. Obviously, people don't get tolerant to that. But then in the middle, you have buprenorphine, a partial agonist, which, as we know, binds to the receptor, activates the receptor, but at lower levels, less reinforcing, less likely to develop tolerance. Now, we all know people can develop tolerance and dependence on buprenorphine. However, much less tolerance than traditional opioids. The way I describe this to patients is that traditional agonist opioids are like a 10 out of 10. Naltrexone's like a 0 out of 10. Buprenorphine's like a 3 out of 10. So they can sort of conceptualize that. If you're visual, this is the same thing, just in a visual way. And you could see a methadone here comes in and it completely turns on the receptor, full agonist. On the far right, you have naltrexone, which blocks it. But then you have buprenorphine in the middle, partially activates it. Yet another way to look at the same thing, again, if you're graphic minded, I want to make sure people get this. The triangles at the bottom are naloxone or naltrexone, and the y-axis is the effect on the opioid receptor, the x-axis is the dose. So not surprisingly, the more naloxone or naltrexone you give, it doesn't matter. It doesn't turn on the receptor. But if you look at the red squares, that's like methadone or heroin or oxycodone, the more you give, the more the effect, and it's a vicious cycle as tolerance comes in. But then you see in the middle, there's that yellow kind of diamonds, the partial agonist of buprenorphine. And you see the more you give, the more the effect up until a point, and then it levels off. In our field, we call that the ceiling effect. The idea being that above a certain dose, and for example, for Suboxone, it tends to be around 24, 32 milligrams, somewhere in that neighborhood, a little higher. Giving more really doesn't do anything. And I'm sure everyone on this webinar has seen people with opioid overdose and knows of that. I'm sure most people, if not everyone, have probably never seen someone with a Suboxone overdose. Now, maybe if they've done concurrent benzos or things like that, by and large, it just doesn't happen. It certainly can happen with kids, but this is one of the reasons we really like it. It tends to be very safe. So which of the following is not FDA approved for pain? Belbuca, Buprenex, Sublocade, or Butrans, those are the trade names. The answer is Sublocade, and now I'm going to go into detail about that. So there was a nice article from I should say a handout from the VA Pharmacy Benefits Services in 2022 that looked at buprenorphine products for pain. This is a little hard to read, so I redid it, so it's a little more legible. So this lists all the products that are out there of buprenorphine. And what I did was listed, so the top ones, buprenorphine, the trade name, Butrans for the patch, and a buccal film called Belbuca, those are the trade names. They are FDA approved for pain. They're long acting. And then you have the combination buprenorphine naloxone sublingual, like Suboxone or Zubsolv. You have this buprenorphine only product, like Subutex. You have a long-acting injectable, like Sublocade. And in another slide, I forgot there's a new product, Brixadi, that just became available literally within the past few weeks. These can be used off-label, and of course, I'm going to spend the bulk of the time talking about that. There is an IV and IM formulation of buprenorphine called Buprenex. We don't have it in our hospital. I'm not familiar with anyone who does. Maybe someone does, but I'm not going to be talking about that. They cost very differently. So Belbuca, for example, again, that's that buccal one for pain, can be hundreds and hundreds of dollars a month, as you see. The transdermal patch, 135. Suboxone generic can be 93. And one of the reasons I'm showing this slide is that the traditional buprenorphine that we know of, such as sublingual buprenorphine naloxone, tends to be a lot cheaper than these newer FDA approved for pain. So yet another reason to consider off-label sublingual formulations. And I don't have the injectables up here, but a monthly injectable of, for example, Sublocade can cost $1,300, $1,500, things like that. Not to the patient, but to the insurer. And of course, we need to be cost conscious regardless who's paying for it. So there's something called Cmax, the highest concentration of a drug in the blood, CSF, or target organ after a dose is given. And I don't want to pretend that I know pharmacology well, but I did look up some different studies about the Cmax of different drugs, different versions of buprenorphine. And here is sort of a summary of all of that. So if you do the suggested dosing, for example, of the transdermal, your levels at a steady state are about 0.224 nanograms per milliliter. Of the buccal, you could see that 0.364. Suboxone, 2.31, that's steady state at 16 milligrams daily, pretty typical dose, right? And then the long-acting is even higher. So the point I'm showing here is that the formulations that we use for opiate use disorder tend to get much, much higher blood levels than compared to the ones FDA approved for pain. Now, the question I have, and it is a question I do not have an answer, is do these higher levels predict clinical response? Do people on Sublocade have 10 times clinical response to someone on the transdermal? Probably not. But it does make you think, and theoretically, there probably is something to that. Who knows? There's no head-to-head studies to look at that. But theoretically, and I emphasize that word, maybe some of these long-acting injectables and the sublingual maybe have better pain response than these ones FDA approved for pain. I don't know. There are also some theories that sort of the pulsatile every hour sublingual that is used for Suboxone, and I'm going to talk in a little bit about dosing, may even be better than the extended release. And that has to do with some pharmacologic properties that are well beyond me. But my point is it's not clear what works best, and we may never truly know. But theoretically, this is yet another reason to think about off-label products that are used for OUD, but to use them for pain. So another question to get people thinking, which of the following is most accurate about buprenorphine as a partial agonist? As a partial agonist, it can help pain only a teeny weeny bit. Research shows as a partial agonist, there is no risk of respiratory depression. Different formulations and dosing can cause vastly different levels in the blood, and a higher serum bup level always means more pain relief. Well, hopefully at this point you're thinking C, right? Because as we know, that it can cause some respiratory depression, theoretically, maybe not major. And as you just saw that what I was talking about before, we don't know about the effect of levels in pain relief, but we do know that different formulations get different blood levels. So does this work? Is it helpful for pain? So this is an article from about 10 years ago, and it's called 12 Reasons for Considering Buprenorphine as a Frontline Analgesic in the Management of Pain. So if this isn't sort of a summary of why we're here, I'm not sure what is, but they list different reasons why the authors suggest that this could be considered. And they talk about the different types of pain it can be helpful with, and talks about that it can theoretically cause less problems and side effects. I put some question marks here. So for example, withdrawal symptoms milder and drug dependence less. I think all of us who have done this long enough know that helping someone off buprenorphine can be very challenging, particularly if they do it too quick. But the bottom line is, and I'm not going to read all of these, is there's a lot of compelling reasons to think about buprenorphine as a frontline analgesic. And I think the safety profile is a big one, and the efficacy. In fact, in 2019, there was an expert panel that talked about buprenorphine as a partial agonist. And what did they say? They said that buprenorphine should be considered before some opioids in patients with a favorable risk-benefit profile based on factors, abuse potential, and tolerability. So here's this panel saying, hey, think about buprenorphine. Now, there's actually quite a bit of studies looking at buprenorphine for pain. Some of them are specific for postoperative pain and acute pain, some for long-term pain. So it's hard to get specifics to make one general recommendation about one thing. I've pulled together some that I found, and again, there's many. So one was a meta-analysis looking at perioperative, just as good as traditional opioids. One looked at chronic pain and, does it get precipitated withdrawal? No, but it still worked. And one thing that I've always told patients about, because buprenorphine tends to have less tolerance, you tend to get less hyperalgesia, right? Hyperalgesia is what causes that hamster wheel for patients where they'll take their traditional opioid and over time feel in more pain along with the tolerance, so they need more and more. And it makes their pain worse over time. And I tell people if they can get off their traditional opioids, in most cases, they will feel better several months out, not right away. And that's the body adjusting from the hyperalgesia. You just don't see that as much with buprenorphine. So again, a lot of good studies, a lot of good evidence that it can help. So another article out there talking about buprenorphine has unique and favorable properties that make it useful. It has been recommended to consider this first line for chronic pain. And they give some examples of when, but as someone said, for many reasons, the popularity of using buprenorphine for analgesia continues to grow. And a practitioner should consider this as an excellent and safe option for chronic pain. So this was in one of these online medical journal things I saw just a few months ago. And when I have residents or students and we're talking about buprenorphine, and if I have a patient come in that we're using it for pain, I'll tell them that I would bet them $100 that in a few years, whether it's 5 or 10 years, buprenorphine will be a first line because it's effective and it's so much safer. Well, I think we're just starting to see that happening. So I had mentioned there's guidelines out there by the Veterans Affairs, the Department of Defense, and what they came out with just recently, the VA said buprenorphine, rather than a full agonist opioid, should be used for patients taking daily opioids for chronic pain, given what? Given its lower risk for overdose or misuse that these new guidelines recommended. And these new guidelines, I talked about pain management and guidelines from the VA. VA had guidelines about opioid management and chronic pain, right? And this is the guidelines. And I'm going to call your attention to one row in what I've put up there. So recommendations for patients receiving daily opioids, we suggest using buprenorphine because of the lower risk. And in their previous guidelines in 2007, they didn't comment on this at all. There was no one thought about buprenorphine. Now they're saying consider it. And it's a weak recommendation, right? They're not saying, hey, change everyone. They're saying consider it, suggest it. It's new. I suspect that in the next couple years, in the next versions of guidelines, we're going to start to see this more heavily recommended. So, which of the following did not recommend considering, and I emphasize the word considering, buprenorphine for pain? An expert panel in 2019, the CDC guidelines for opioid management, the VA DoD guidelines in 2022, or several published articles, including systematic reviews and meta-analyses. So hopefully you got it. That B, the CDC guidelines. And by the way, there was a revision just last year because there was so much outcry about it because people took them literally, and there was this big wave of undertreating pain. So they came out with a revision, but they didn't talk about buprenorphine in those guidelines, not for pain. But there is a lot of guidelines out there and evidence suggesting to consider buprenorphine for pain. So which of the following is most accurate? Evidence suggests that buprenorphine can be helpful, but not even close to traditional opioids. The little available evidence has only explored pharmacokinetics. There's no real clinical outcome, such as whether it actually helps pain. There is strong evidence proving a very significant clinical response. Or there is some evidence proving a mild to moderate clinical response. Well, I think for now, the best answer is D. Now, this may change over several years. We'll see. The evidence out there does suggest it's approaching traditional opioids in many cases. It's, can be very helpful. And it has looked at clinical outcomes, not just pharmacokinetics. But again, it's not overwhelming yet. We're still in the early stages. Well, not so fast. Not surprisingly, when it comes to buprenorphine for pain, that is off-label. And one author said in a nice paper, hey, more research is needed. Dosing guidelines, how we're going to do this. It's exciting, but hey, we still have a lot of questions. And I think I just want to emphasize that, right? That this is not the end all be all. We don't know yet. This is still early. And I just want to emphasize that. Another thing that I think is so important is that elephant in the room, stigma, right? We all know how many healthcare providers respond when someone's got a history of addiction, when someone's on buprenorphine product, right? We all know that there's many healthcare providers who are doing a medication reconciliation, and the patient says, oh, I'm on Suboxone, and the provider does this. I don't know if my camera's still on, but basically I gave a rolling eye smirk, which is basically the body language, which says it all. And so there is a stigma. And so we have to remember that if we put a patient on a medicine like buprenorphine naloxone for pain, it's going to be on their record. It's going to be on their chart. So what about this opioid use disorder versus dependence issue? Well, recall that when you're trying to diagnose a use disorder, we're using the DSM, the Diagnostic Statistical Manual version 5 criteria, right? There's a list of 11 criteria. And recall that depending how many criteria the patient has determines whether or not they have a use disorder and the severity of the use disorder, right? So I listed that all here. The reason tolerance and withdrawal I put in red is because many people may not be aware, but if someone is prescribed prescription opioids, you're really not supposed to count those criteria as the criteria of opioid use disorder. Why? The committee who developed this wanted to avoid an OUD diagnosis for someone taking an opioid as directed and getting physiologic tolerance, right? Many, I don't know, most on chronic opioids will get at least some tolerance. They don't probably meet, many of them, most of them don't meet criteria for OUD. So I just point that out, kind of makes it even a gray zone, right? So if you take out those two, but someone's been prescribed oxycodone, they're getting tolerant and they're craving it more because they're in pain and they want it more. Are they craving it more? And that's a check for OUD. Or are they just in more pain? If they're in so much pain that they can't go out, are they giving up activities and isolating? Check for the checklist. Or is that just pain? And that would not be a criteria for this. It is very much a gray zone. The other thing is that the DSM people, the VA article had a nice thing calling them diagnostic orphans. And exactly what I'm talking about, the DSM has created orphans. These are people who are on chronic opioids with tolerance, with withdrawal if they stop, maybe another symptom on that checklist, right? Again, the clock watching behaviors, and is that craving or just they're in pain? And so they really may meet criteria, they may not. What's the ICD 10 definition of dependence versus the DSM, right? There's a lot of ambiguity. So I'm just saying all this because if you're confused, if you see someone that's on opioids and they're going through quickly and someone says, are they addicted? Do they have an use disorder? And you're like, I don't know, you're in good company. It's very much a gray zone. But one critical issue when we're looking at buprenorphine and looking at studies, we want to be as clear as possible if we can. Are we treating chronic pain? Are we treating opioid use disorder? Are we treating both, right? And that's challenging, but that's something that we're supposed to, think about. So in terms of opioid dependence, so what's the difference between physiologic opioid dependence and opioid use disorder? I just talked about how it's a gray zone and hard to say. Well, some people may say, well, wait a minute. Well, insurance companies pay for buprenorphine for pain. I should say the off-label formulations like the sublingual buprenorphine naloxone. Well, if you look at the FDA labeling, they're really mostly labeled for dependence, opioid dependence. Now, the good thing is the ICD-10 for dependence, use disorder, they all kind of map to the same. So if you put them on it for opioid dependence, you're good to go for the most part. I've been doing that for a while. I thought, boy, I'm so smart. I figured that out. Well, the VA was ahead of me, so I can't take credit. So when I get that question, is it covered? It is. Not all, but the vast majority of time, I'm seeing someone with pain that I'm considering buprenorphine. The vast majority of time, they're on or have been on traditional opioids and have developed some sort of physiologic dependence, right, as most people on opioids. So I'm very justified. So how do you dose this? Well, some things that I think about is this. When I'm, let's say, on the fence, buprenorphine, traditional opioids, some of the questions I ask is, does the person have a history of major problems with drugs or alcohol? Right, that may push me towards buprenorphine. What if they have comorbidities and risks for opioids? Maybe they're on benzodiazepines, and though benzodiazepines can interact with buprenorphine, much more of a risk with traditional opioids. And of course, you all know how risky that is of benzos and opioids. Maybe they have sleep apnea or other risks for respiratory depression where you'd be worried about escalating doses of traditional opioids. A risk of diversion or stealing medications may or may not lead you towards buprenorphine. And of course, someone who's had adverse reactions or just a poor quality of life from traditional opioids. That's actually something that I see quite a bit. Someone who's been on opioids, who's sick of being on what I call that hamster wheel. They're tired, they're sluggish, they're constipated, they're constantly taking more medicine, but they're sitting on the couch. It's not helping their function. So this can be something to consider. Well, I just mentioned that there's different formulations. When would you do what formulation? Well, for me, if I have someone that has no history of opiate use disorder, they have good insurance that may cover those expensive products like the transdermal or the buccal, and they're not already on opioids or maybe on a tiny dose, I may try the transdermal or buccal first, right? Why not? I want to try the first line, sort of the FDA approved, and go from there. They are very expensive. So that's my biggest, downside of it, but certainly worth trying. I'll do sublingual, like the buprenorphine naloxone product for pain, if they've been on the transdermal buccal and we're not getting anywhere. If they have an OUD history, as I talked about before, or someone who's on a higher dose of traditional opioids and already getting some problems, some dependence. To me, if someone's on a good amount of opioids and they're already going through that hamster wheel, needing more and more, calling in for early refills, getting side effects, then I do worry that, the fairly low potency of the transdermal product may not work anyway. So for those, I may just go right to the sublingual. And I'll go to the extended release products, someone who's already on sublingual, it's not working, there's very short-term relief, logistics, they can't remember their medicines, they can't keep them secure. I have to look at insurance coverage. And of course, someone who, just like we do with opiate use disorder, patients on sublingual and opioid use disorder, someone who's not coming in regularly, whose urine drug screens are aberrant, who's missing strip or medication counts, some aberrant behavior, then I may put them on the long-acting. This is the same thing, just visually, again from that VA pharmacy benefits article. And you could tell that this is about a year old because they talk about X waiver things here. What this is saying is that to put someone on that transdermal patch, you didn't, or the buckle, you didn't need an X waiver. Any DEA, any provider with a DEA could do it. Now, as I mentioned, not only can anyone do that, but anyone could do the sublingual. So this is a little outdated, but what they say is if you have a patient with pain and they have no history of dependence before, you could try the transdermal, the Belbuca, maybe the sublingual, and look at their response, and then go from there. And someone with a history of dependence, then you can consider going right to the combination sublingual. So what about, again, the FDA labeled versus the off-label? So again, I tend to start with the others. Sometimes I'll start with the FDA approved, even if I'm not sure if it works, just because it is FDA approved. That way, sometimes I may have better luck with the insurance. That way I can appeal and say, hey, I tried the FDA approved, it didn't work. So what about starting, right? And those of us who do buprenorphine management know that starting people, especially in the era of fentanyl, when it gets in your fat and lasts for several days and you don't know when to start, starting people on buprenorphine can be very challenging, right? We don't want to cause the so-called precipitated withdrawal, or what patients call precip. And in at least this study, what they found is that most patients in the traditional initiation group versus the micro-induction group did fine. And there's a bunch of transition strategies in the literature effective for patients with OUD, pain, or both. So how do you start? The traditional approach is when someone's on an opioid, whether it's illicit heroin or fentanyl, or they're on their oxycodone and they want off that hamster wheel. They're prescribed it by someone, legally, and the person takes it, but they want off. The traditional starting of buprenorphine sublingual is, okay, stop your oxycodone, stop your opioid. In about 24 hours, you're going to be really, really uncomfortable and bad withdrawal. Don't worry, I'm going to give you medicines to comfort you for your withdrawal symptoms, so-called comfort medicines, for the next 12 hours or so, 24 hours. But after about 24 hours, when you're crawling out of your skin and you can't take it, and the comfort medicines aren't working, then you start the sublingual bupe, because then you'll have a minimal chance of precipitated withdrawal and probably do fine, right? That's the traditional approach. Now with fentanyl, we often say the same thing, but wait 2 to 3 days, who knows? More and more, there's an approach, some people call it microdosing. I think the more PC term is low dose induction, because microdosing has a connotation of what's being done with some psychedelics to treat PTSD and other things. The idea of low dose induction is giving people tiny, tiny doses of the buprenorphine while they are still using their opioid for people who can't stop or can't stop long enough. You do tiny doses, gradually increase, for example, over a week. Then they're on a full dose of buprenorphine, and then you just stop the opioid. And there's many different algorithms out there. We can go over if we at some point, but something that's being more and more done. I have found actually, like many people, very good success with this low dose induction. And actually, I found particularly good success with the low dose induction for patients on chronic opioids, because it's such a predictable opioid they're taking. In other words, someone who's transitioning from a prescription opioid as compared to something on the street to buprenorphine. I remember one of the first times I tried the low dose induction was on a guy in his 60s on chronic opioids. He came to the appointment with his daughter, who happened to be a nurse who works in a detox center. And when I talked to them about trying this low dose induction, she was like, no, Dr. Radosh, I'm really, because she's seen precipitated withdrawal again and again. And I said, listen, that's understandable. I think this is going to work. Well, it worked beautifully. He did great. And he's been doing great for 2 years now. Just, he's wonderful. He got off some other medicines, so he looks great. So again, if they're not already on opioids, you could just start buprenorphine. If they're already on opioids, you want to think about starting by preventing that precipitated withdrawal. And again, there's 3 options if they're already on opioids. One is to do a super duper slow opioid wean over many, many, many months, right? We want to do it very slow. The other, I talked about the traditional induction, and then the so-called low dose induction. Again, this is its own topic. There's so many things out there, but something to really think about. And if you're not too familiar yet with the low dose induction, be sure to be familiar. It's a great option. Different guidelines, SAMHSA, ASAM, the VA, all talk about this, and I put the references there and put the quotes from there. I'm not going to read each of these quotes because they all say the same thing. What does that say? If you are using buprenorphine for pain, it should be dosed more frequently, like TID, maybe even QID. Right? For opiate use disorder, we have people on daily or often BID. But if someone's taking it for pain, it should be TID or QID. And by the way, as people may know, it's the same thing for methadone, right? Someone on methadone for pain should be several times a day. And pretty much all the guidelines suggest that. And so let's say you're taking care of someone on buprenorphine on BID dosing, and they tell you they have chronic pain, maybe even just switch to a TID regimen. And that can be very helpful. So how do you start?
Right.
So, oh, hello. Oh, I thought I heard someone. So if you're looking to do the buccal, the transdermal, just follow the instructions like in Hippocrates. It'll give you the dosing there, and I'm going to come to that in just a moment. For the sublingual dose, what do you do? Well, there's a lot of factors involved. Is this someone who's been on chronic opioids? Do they have high tolerance already? Are they on many, many other medications that can cause CNS depression? Are they sensitive to medications? That may inform your decision about what dose to do. And remember, when we're doing this dosing, remember I said that a lot of times we should do it TID dosing, and we may have to work with patients to find what works for them. It often involves cutting the strips or the tablets. And if you look in the labeling, you're not supposed to do it. Technically, it's off label. Everyone cuts their strips. It is fine. It is absolutely fine. But I always tell patients that when I'm talking to them about cutting strips, to say, listen, you may see in a package insert, it's fine. And I also reassure them, hey, this isn't chemotherapy. If I want you to take 4 milligrams of an 8 milligram strip and you cut it, and instead of 4 and 4, it's 5 and 3, you're fine. Right? I reassure them because I don't want people to get worried. In many cases, I'll actually start 4, 4, 4, like 4 milligrams in the morning, 4 in the afternoon, 4 in the evening. Why do I do that? It's sort of in the middle. I could easily go down or up depending how I need. Also, I often prescribe the 8 milligram strips. Why? Number one, it makes flexibility in dosing because people can take a quarter or a half. They don't need 3 different prescriptions. And anecdotally, I think pharmacies stock that much more easily. I know when I've written for 4 milligram strips, it takes a long time for pharmacies to get it. It's harder for the get. These days, I've not had a problem TID. In the olden days when we first started doing this, I did. And I would just write for something like 1.5 strips a day and tell the patient to do half strip TID. Because sometimes in electronic records, you'll get a pop-up that says, this is not supposed to be dosed more than twice a day. Not been an issue recently. I think it's really important to review with patients how to take buprenorphine. I've been doing this long enough that I'm still amazed. I'll see someone who's been on this for a year. We're at another practice, they come to us and they say, yeah, it's been great. I can't stand that nausea and that bitter taste and stuff. And I say, yeah, how are you taking it? And we go through and they tell me that they're swallowing the saliva. And I say, listen, there is a bitter taste to it, but boy, that nausea, that can be minimized by not swallowing the saliva. So I go through step by step. In fact, in my computer record system, I have what they call a dot phrase, something that quickly pulls in these exact instructions into my patient instructions so they have this written down. I want to emphasize this to them. And I remind them that it's really hard to do. Not swallowing spit is really hard to do. I think it's important that if you're using buprenorphine for pain, it is still a controlled substance. I think we do, as a healthcare system, such a poor job of monitoring patients on controlled substances, whether it's benzodiazepines, whether it's opioids for chronic pain or others. So you still want to do periodic urine drug screens, medication wrapper counts, things like that. And you still want to look for side effects, constipation, should they be on a bowel regimen, things like that, right? Very common reason for patients to stop, but we could help with that. So I wanted to leave some time for discussion and questions. So I hope at this point that you see and can list some of the evidence supporting buprenorphine's use in pain, that you can get a sense of some patients where you should consider buprenorphine for pain, and have some ideas of how you can initiate and manage buprenorphine for pain. I also want to talk about some takeaways here. So please at least consider buprenorphine for pain, especially those patients with opiate use disorder or physiologic dependence. Again, the evidence is limited, but it's really growing and promising. And I think that the guidelines in a few years will really catch up and make it probably even first line, because there's many advantages over traditional opioids. There's different formulations, and you need to really think about that and how you're going to approach the patient with that. And they're always changing. Again, if you're doing the sublingual dose, to think about TID. And again, I put in here tons of slides of cases, resources. What about the safety and sealing, things that I didn't think we'd have time to get to. So with that in mind, wanted to open it up to any questions or comments or experiences.
Wonderful. Well, that was fabulous. If people either want to throw it in the chat and Aaron and I will get to it, or you can unmute and interrupt one of us. I'll start out with a question, and I suspect Aaron always has questions, but I get a lot of my referrals. I get a lot of referrals from the pain clinic, but I suspect you may as well. And one of the other things that I bump into is people have been on the same dose and now they're 75, and then somebody gives them a benzo and they overdose and end up in the ER. And it's that changing physiology too that we always have to. I think then buprenorphine becomes a player because it doesn't have those issues. Have you had that same experience?
Yeah, I think quite a bit. I have people who inadvertently overdose. The pain management provider appropriately is worried. And a lot of those patients are very good candidates for buprenorphine. It's so much safer. Having said that, there are times when I'll go through the history with the patient and realize there's no aberrant behavior, red flags. It was just this interaction, and say to the patient, the pain provider, listen, I think buprenorphine may be a good option, but it's not necessary. Maybe go back to a lower dose or stop that benzo, have the naloxone, so I don't want to, I don't want to make it so pain providers or others think that they're going to come to us and automatically get bup in all cases. But I do see that quite a bit where there's complications from their opioids. And I've seen that, just like you said, and it's often the benzodiazepines or just polypharmacy. Someone's on an SSRI and trazodone and gabapentin and this, and then they blame it all on the opioids, yet they're on 10 other medicines.
Aaron, questions?
I do. I think it's always helpful knowing how to approach patients in these difficult conversations sometimes. So if you have a patient that, indications for transitioning them from a full agonist opioid to the partial agonist buprenorphine, do you have sort of a canned phrase or canned talking points that you use? Because this is a little anxiety producing for them. And what do you say? How do you approach that?
And actually, I have a whole lecture I've given residents before about this exact thing, how to have these conversations. I think most importantly, it's to ground it in objective evidence. So I think that's the providers don't do a good job of that. We say, oh, you can't be on opioids. I want you to be on this, without saying, I saw you've been on opioids for a long time and your dose has been going up over time. And boy, from what it sounds like, you're constipated, you're this, you're that. From what you've described, it doesn't sound like a great quality of life. There's this other option, blah, 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 blah. Similarly, I hate it when providers lie. What do I mean by that? Someone's on opioids and the provider says, I can't give you opioids. Yeah, you can. You just don't want to. And there may be a good reason you don't want to. That's okay. There's nothing wrong with saying to a patient, hey, listen, I know you're interested in these traditional opioids, but when we look at your pattern and your history, I'm very worried about that. And I can't, in good conscience, start an opioid. Let's do the buprenorphine. It's a lot safer. Or I explain buprenorphine is this medicine that was started for opioid addiction, but it turns out it's being used for pain, and there's all these evidence now in guidelines. Wow, why don't we do that? So I just try to be objective, not accusatory, and see what the patient's reticence is. Maybe it's labeling more than anything. And then you could say, oh, and I'll do this with patients. And I say, no, you don't have use disorder. Here's my criteria. You don't meet that, but you have pain, blah, blah, blah. So
our friend Dave asked a question that we bump into in our clinic quite a bit, which is when you get somebody with acute pain, and I'm dealing this morning with somebody who just had surgery on Bupe. And what's kind of your go-to opioids for those patients short term?
Right. So the old thinking was often if someone's on buprenorphine, even methadone to some extent, was, oh, you're getting surgery, stop the buprenorphine a couple of days before. That way we can give you opioids and then we'll restart it after. And of course that makes sense conceptually, but it also is fraught with problems on so many levels. So the teaching now, what most people do is we look at the buprenorphine or methadone as a baseline, and you treat the pain on top of that. But to Dave's good question, when people are on buprenorphine, it is blocking the mu receptor. What do? What we'll do is we'll make clear as much as we can to the surgeon, to the managing team, that patients on buprenorphine usually need higher than usual dosing or more potent dosing. So someone who normally gets 5 milligram post-op for oxycodone will do 10. If that doesn't work, I'll say to the surgeon, morphine, Dilaudid if you need, whatever works temporarily, because for most hospitalizations, most surgeries, it's only a few days worth. What I find so sad is many of our patients are going to be on buprenorphine. Someone puts them on the usual 5 milligram oxycodone. They say to the nurse, it's not helping, it's not working. And the whole team says, oh, drug seeking, you see? No, it's physiology, which is very sad. So we need to be advocates. So
or they say, stop the Suboxone. I've seen that.
And then you're left to clean up the mess, right? Then they call you, hey, how do we restart this? And you're like, okay, low dose induction or things like that. Do you ever combine Bupe and another opioid in terms of the central sensitization? Do you know what? I actually have one patient who's got a history of sickle cell that I have on that in theoretically. The idea being that what I'm hoping is that the baseline buprenorphine I have her on kind of blunts any euphoric effects, things like that, but she's still on some chronic traditional opioids from pain management. I don't know if it's placebo. I'm not sure, but I do think it's been working for her, so we've been continuing it. So the answer is yes, sort of, but I don't know of any strong data. It may be out there. Certainly reasonable to try, but I don't, as a rule of thumb, do that. But again, I do have one patient on it, sort of like that. So.
I suspect you also see some of these things I see where people come in with a preconceived idea of what Bupe is going to do. And I see them coming from the pain clinic and we'll have the buprenorphine discussion. And their first thing is, I don't think this is going to work, right? I've talked to people and it's just not going to work. And, where do you go with that particular angle when a patient's really digging their heels in?
Right. So first I say to them, at some point in the conversation, I explain, why I think it is, but at some point then I say, hey, just so you know, you're the patient. It's your call. It's not me. It's not about me. I couldn't care less. I kind of say sort of that. But the reason you're here is because blah, blah, blah. Kind of let them know that this is not about a power struggle. Because I think a lot of providers make it a power struggle. I want them to disarm them right away. But I say, I understand why you'd say that. Traditional opioids, I'll be honest, are stronger on the receptor than buprenorphine, milligram for milligram. However, in the long run, going to do so much better than the bup because your body has gotten used to the. And then I tell them stories. I say, hey, listen, I had a guy who was 70, who was, this is going back a few years, Vietnam vet, who actually is probably older than now, and got injured and had been on chronic opioids for decades, hated it. We switched him over. 2 months later, he walked into my office on it, like spry, and says, Doc, I wish I had done that years ago. I tell stories like that, and I say, look, I'm not promising you're going to have that response, but hey, isn't it worth a try? You know, I kind of do that. But some people have fixed notions. It's a great point. You know,
I can do the same thing too, and I'll just say, listen, I'm happy to send you back to the pain clinic. I'm we're going to give this a try. They asked me to try it. Are you in? You know, let's give it a shot. And but I do the kind of that same thing. It's like, well, I'm happy to send you back. I don't prescribe opioids here, but we'll see how it goes.
Yeah,
so
that sounds like a good approach.
Yeah, and most of them are okay with it, but boy, you get those people, and they've read before they came.
Right.
They went to Reddit, So, any other questions? Boy, that was a great talk. I love this talk.
I have one more actually.
All right.
So CMAX is a term before, which I thought was super interesting. So are you always using films being they have better bioavailability, or are you using tablets sometimes in patients where you're having insurance coverage issues?
I think my understanding is that the films and the tablets, the sublingual, pretty much have the same bioavailability. So it's really the buccal films. That's the product called Belbuca. That's the trade name. That's FDA approved for pain. They have it's a smaller dose. It's like 300 or 450 micrograms as compared to the sublingual buprenorphine products like Suboxone or Zubsolv, which has a dose of about 4 or 8 milligrams. So the tablet and the film, it's really a personal preference. Sometimes insurance steps in, but I have a lot of patients, the film tends to be small, convenient, fairly easy to cut. So I'd say most patients prefer that. I have some patients who say, hey, it doesn't dissolve well. When the tablet's in, I could feel it dissolves. One patient I saw this morning, she had a stroke and one of her hands she can't use well. So she says, look, I wish I could do the films. I can't because I can't open the packet, things like that. So I think it's a good question. I think either is reasonable.
Thank you.
Well, we're already getting a lot.
Hi, this is Marlene Wood. I was just wondering, is there any financial help for the people that are on Medicare disability? I had quite a lot of difficulty that they could never afford the transdermal Buprenorphine.
Yeah, I don't have an answer to that. And frankly, it's one of the many reasons I tend to go more and more right to sublingual because it is so expensive, and insurers are, and even when they do cover it, there's often prior authorization needed. And the irony is, in general, and this is anecdotal, it's not quite as strong for the most part.
Yeah.
So I haven't had much luck with that, except for prior auths here and there. But it's worth saying to the patient, hey, listen, this is FDA approved. And I do think it's important to say, look, this buprenorphine, I'm going to give you this sublingual. It's used all the time for opioid dependence, which you kind of have. It's not approved for pain. It's the same exact medicine as the ones that are, but I just need you to know that. So,
Yeah.
Marlene, if you figure that out, please let me know.
Thank you. Thank you.
It's not you.
Yeah, and actually, it wasn't too long ago. Medicare was very difficult to get regular Suboxone, buprenorphine / naloxone from, and honestly, a lot of the patients that I get from the pain clinic, I suspect you see this as well. They've tried the patch, and so that's also one of their things as well. I've already tried that medicine, and I always say, well, it's a little bit different. The dosing is different, the levels in your blood are different, and so I typically don't do patches from my addiction clinic, but yeah, that's
exactly
a great.
something I say.
Yeah.
So
Go ahead, Dave.
One thing is the tabs do not cut well from what patients say. So the films are much easier. And if you use a 2 milligram film, you can cut it down to 1/8 and get to like 250 micrograms.
Yep. That's a great point. I have patients who get there with a razor blade when they're at that like it's more of a mental, and they admit that. That's a great point, because the tabs you can sometimes split in half, but even that is pushing it and beyond that, which is why I kind of put in the slide. I think the films are usually my go-to. I think that's a really good point. It's, yeah.
And I had a question. Has anybody else had patients who have been having trouble getting it lately? I've had several patients, at least here in Minnesota, call back and say, can you send it to a different pharmacy because they're out?
Wow.
Yeah, and actually we've had some issues with that in St. Cloud. So we have seen that where they're running out. And I'll just say this too, and I'd be interested how you feel about this. We often have places switch from generic to generic to generic, and the absorption of those is vastly different. And so we'll all of a sudden get all kinds of calls because they've put 10 of our patients on a different generic and they're all in withdrawal. I don't know if you've seen that, but
yeah, and that's real. When patients talk about that, that can be very real. So eventually a lot of patients will know. I have a couple that tell me what generic brand. So they don't, it's not even the brand necessary. It's, hey, call this pharmacy because they carry this company's, not this pharmacy. So I do see that exact thing as well.
perfect.
Yeah. If anyone down the road has any questions, anything I could help facilitate, please let me know. I think I put my email in the slides, and certainly, Katie and Kurt and everyone have my email. Again, thanks for having me. It's such an important topic, and I appreciate these great questions and great discussion.
Yeah, and Lee, boy, if you ever want to come back, you have a talk you'd like to throw at the group, we, really appreciated your talk. It was a really well timed too. So
Okay, great,
so
thanks.
thanks so much.
All right, have a good day. Take care.
Thank you.
All right, thanks everybody, and we'll see everybody next week. We have Haida here next week talking about the trends in Minnesota. So she's always a great speaker too. So, all right, take care.